It's a pleasure to have the opportunity to share with you some insights into the upcoming 2021 WHO classification of CNS tumors. This is a mock-up of the cover, and the hope is that the book is out later this summer. I don't have any financial relationships to disclose, and my learning objectives are listed there. It's important to emphasize that the accurate classification of human tumors is done for a number of important reasons, not just the care of individual patients like we're all involved in, but also for clinical trial interpretation, for the analysis of experimental studies, for understanding epidemiological studies that may implicate etiologies, and for the allocation of resources by governments to support healthcare. As a result, periodic revisions of tumor classifications have diverse and important effects on many aspects of individual health as well as population health. But it's also important to emphasize that tumor classifications are imperfect representations. They reflect the state of understanding at a particular time and the interpretations of a limited number of experts. As such, they're best to be thought of as works in progress. The WHO has put out to date 5 classifications. Even though this upcoming one is labeled the 5th edition, that's because 2016 was formally an update of the 4th edition. When you ask what are the major differences between the 2016 updated 4th edition and the 2021 5th edition, it's a pretty simple answer. And the answer is that most of the changes, or at least most of the major changes, came out of the work of C-IMPACT, the consortium to inform molecular and practical approaches to CNS tumor taxonomy. So if you've been following the C-IMPACT updates, you already have great insights into what the 2021 classification will look like. There were a number of differences in the creation of the 5th edition from earlier editions that I was involved in. Some of these were positive. The C-IMPACT existence made the process really manageable. There was less of a hectic nature at the actual meetings, and that was particularly important since COVID meant that those meetings were virtual. And we had many people beginning in the middle of the night and going to noon, other people beginning late in the day and going to early in the morning. It was a very difficult process. The CNS number 5 will be more digital. It will be digital, period, and you will be able to access it much more readily online, and that's, I think, a very positive. And the fact that it's become more digital allowed a quicker turnaround time to a new edition. On the negative side, however, the WHO meetings were virtual because of COVID, and there's no comparison of these virtual meetings to the in-person meetings that we had in the past. In addition, no single responsible neuropathologist served as an overall editor, as opposed to in the past when there were single responsible editors. As a result, there is much more variability from chapter to chapter in this upcoming Blue Book than in the past. And I put in quicker turnaround time to a new edition in the negatives as well, because for some of the reasons you do classifications, too quick updating can be deleterious as well as advantageous. There are many major changes in this upcoming CNS. They are general changes and they are specific changes. I clearly don't have time to go into all of these today, and so I'll refer you to a review article that is in press in Neuro-Oncology. It's not in any of the other journals. It's in Neuro-Oncology. It should be out within the next few weeks to a month, and that will have all of the details on the changes included. So let me talk about a few of them. I want to talk about tumor grading because there have been some substantial changes. So for one, we are using Arabic numerals rather than Roman numerals. This was done to conform with other WHO grading systems, which use Arabic numerals, and also to decrease the likelihood of typographical errors when grading within types, and I'll tell you about that. Grading within types is a substantial change. For example, now there's one type of IDH mutant astrocytoma. It's called astrocytoma IDH mutant, and then it's given a WHO grade, or what we're calling a WHO CNS grade from 2 to 4. This affects the nomenclature. There's no more anaplastic astrocytoma or anaplastic oligodendroglioma. We also have used combined histological and molecular grading. For instance, you can be a glioblastoma IDH wild type on the basis of histological findings or molecular findings, or both. In addition, we've kept the idea of clinico-pathological grading. So it's still an overall clinico-pathological grade rather than a strictly histological grade. We've used the term WHO CNS grade, since some aspects still differ from the way other WHO systems do their grading. For instance, in the example of astrocytoma IDH mutant, we begin with grade 2 and go to 4. Most WHO grading systems, even for malignant tumors, would begin with a grade 1. In addition, it's not purely clinical grading, because a high-grade tumor that's curable, like a germinoma, remains a grade 4 despite the high cure rate. And there was a consensus that in certain situations in which grade could confuse clinical practice, it might be prudent to omit grades in a report. So here's just a brief summary of some of the major changes in grading over the different types of tumors, either new entities that got new grades or entities such as myxopapillary ependymoma, which was now given a grade 2. So let's talk about the astrocytomas IDH mutant. Astrocytoma IDH mutant WHO grade 2 is a diffusely infiltrative astrocytic glioma with an IDH mutation, and it has the same features as we used to use to define grade 2 astro: low or undetectable mitotic activity, and the absence of high-grade features, so no microvascular proliferation, no necrosis, and no homozygous deletions of CDKN2AB. For the grade 3 tumors, it then has significant mitotic activity. We realize that that is not a very clearly defined set of criteria, but that's as good as it gets from the available literature. But again, microvascular proliferation, necrosis, and the homozygous deletions of CDKN2AB are absent. The grade 4 tumor, on the other hand, note that we don't use the term glioblastoma, has either microvascular proliferation or necrosis or homozygous deletion of CDKN2AB. For glioblastoma IDH wild type, I'll point out that the only place we're using the term glioblastoma is in the setting of IDH wild type. So glioblastoma is an IDH wild type diffuse astrocytic glioma with microvascular proliferation or necrosis, or one of the following 3 molecular features of glioblastoma. Another way to think about it is if you've got an IDH wild type diffuse astrocytic glioma, you can have any one of these 5 features and call it glioblastoma. So this raises an interesting set of scenarios that confuse the way we used to use the term glioblastoma. So let's take the situation of a diffuse glioma without microvascular proliferation or necrosis. In other words, it's not histologically glioblastoma. It still can be a glioblastoma if it has EGFR amplification, TERT promoter mutation, or +7, -10. On the other hand, you could have a scenario in which a diffuse glioma has histological features of glioblastoma, but is not termed a glioblastoma. This would be one that looks like a glioblastoma under the microscope, but that has an IDH mutation, that would be an astrocytoma, IDH mutant, grade 4. The other key feature to emphasize is the use of NOS and NEC in integrated and layered diagnoses. The NOS and NEC designations were present in C-IMPACT as well as in some other publications, but now we're really encouraging its use outside of specific scenarios. So the way you can use NOS and NEC is the following. If you can make an integrated WHO 2021 diagnosis, go ahead and do it. But you can use NOS if you don't have the necessary molecular information to make a diagnosis, either because the test isn't available or you tried to perform the test and it was unsuccessful. On the other hand, NEC is used where you can do the test, but the results don't readily allow for a WHO diagnosis. So you can consider if an integrated WHO diagnosis is possible, but if it's not, use the so-called descriptive diagnosis, or NEC, not elsewhere classified. And both of these serve as red flags to an oncologist or other pathologist that you're not yet at the point of an integrated WHO 2021 diagnosis. The layered diagnoses are the ones that we've talked about now since the Harlem criteria were published. This is top line of an integrated diagnosis, which would be typically a WHO one, the histology, the CNS WHO grade, and the molecular information. So just to give you two examples, here's a supratentorial ependymoma, NOS, clearly ependymoma. Looked like a higher grade ependymoma, but when you did the extraction to look for various nucleic acid changes, they were insufficient. And you couldn't do the molecular studies, hence the NOS designation. On the other hand, here is an interesting example I'll talk about. This is diffuse low-grade glioma, MAP kinase pathway altered. In this situation, it looked like an oligo. The entity doesn't have an assigned WHO grade, and there was FGFR1, a tyrosine kinase domain duplication, which would put it into this subtype of diffuse low-grade glioma, FGFR1 TKD duplicated. If you have more questions on this, obviously this has been discussed a fair amount in the past in C-IMPACT and in the Harlem criteria. But let me go on for the remaining 10, 15 minutes or so, just to talk about the specific changes within tumor groups. There are now 14 new gliomas and glioneuronal tumors recognized. I won't go through all of this list, and I'll just highlight a few as we go along. But there are also 8 new other tumors. These are the non-gliomas and glioneuronal tumors that have been added to the classification. 3 of these you'll see are in italics, which means that they are provisional entities. That is, that the literature was moderately convincing, but not fully convincing that they were really well-characterized entities yet. So we also revised the nomenclature or placement of certain entities. We talked about astrocytoma IDH mutant is now graded within the type, and there is no IDH mutant anaplastic astro or glioblastoma. Diffuse midline glioma is now considered altered rather than mutant because there are different mechanisms that underlie their formation. Chordoid glioma, the location was dropped. Astroblastoma has the MN1 alteration added for specificity. The name of what used to be called REL-A fused ependymoma is now supratentorial ependymoma, ZFTA fusion positive. Embryonal tumor with multi-layered rosettes has had the genetic modifier dropped because there are multiple genetic ways you can get to that tumor. And then there were other changes to conform with soft tissue and other nomenclature, as you can see here, and some subtypes that were made into full types. Amongst the gliomas and glioneuronal tumors, a major change is that we now separate the diffuse gliomas into three types or three groups: adult type, pediatric type diffuse low grade, and pediatric type diffuse high grade gliomas. And then the other ones that you already know: circumscribed astrocytic gliomas, glioneuronal and neuronal tumors, and ependymal tumors. So these are major changes: the division of the diffuse glioma into adult type and pediatric type, which has been years in coming. The pediatric types are further subdivided into low-grade and high-grade diffuse astrocytomas. We've simplified the classification of the common adult type ones, and we've changed, as I've mentioned already, the nomenclature and grading of the common adult type diffuse astrocytomas. I'll emphasize that when we talk about adult type and pediatric type, we realize that some adult type tumors occur in kids and some pediatric type tumors occur in adults, which is why we don't use the term adult and pediatric, and recognize that these are all works in progress. So for the adult type diffuse gliomas, we've gone down from over 10 to just 3. Astro, IDH mutant, oligo, IDH mutant, and 1p19q co-deleted, and glioblastoma, IDH wild type. That's it. And you would grade within those first two types. For the pediatric type diffuse low-grade gliomas, there's diffuse astrocytoma, MIB or MIB-L1 altered, angiocentric glioma, the plenty tumor, polymorphous low-grade neuroepithelial tumor of the young, and then a nebulous category of diffuse low-grade glioma, MAP kinase pathway altered. And for the high-grade pediatric types, it's the H3K27 altered diffuse midline glioma, the new diffuse hemispheric glioma H3G34 mutant, diffuse pediatric type high-grade glioma H3 wild type and IDH wild type, another somewhat nebulous group, and then infant type hemispheric glioma. So just to characterize or comment on these two more nebulous groups here, the expectation is for each of these, they would get worked up in more detail at a genetic level. So for the low-grade tumors, some of the more common ones are the ones that I illustrated with FGFR TKD duplication, FGFR mutations, BRAF, and so on. And for the high grades, you would go on to work those up, and they have corresponding subtypes as well. For the circumscribed astrocytic gliomas and the glioneuronal and neuronal, I've highlighted here the 4 entities that have now been added as formal types: high-grade astro with pyloid features, the diffuse glioneuronal tumor with oligodendroglioma-like features and nuclear clusters, myxoid glioneuronal tumor, and the MVNT that was mentioned in the last classification, but not included as a full type. The other group for which we've made substantial changes is for the ependymal tumors, and we've gone on to do a number of major changes in ependymomas. We now subdivide them into supratentorial, posterior fossa, and spinal. So amongst the supratentorial ones, there are those that are ZFTA fusion positive, those that are YAP1 fusion positive. For the posterior fossa ones, there are the group PFA and the group PFB. There's myxopapillary ependymoma, which I mentioned is now grade 2. And there is the new spinal ependymoma, which is MYC-N amplified. For embryonal tumors, the classification looks pretty similar to the way it looked in the past, with a few significant changes. So for medulloblastomas, there are now multiple subtypes that are molecularly defined that are listed in the classification and have been reviewed recently. And for the other CNS embryonal tumor types, CRENET has been added provisionally, the B-core tumor has been added, and FOXR2 has been added as a qualifier for the definition of CNS neuroblastoma. So I'm going to stop after that very rapid overview and thank all of the people in C-Impact that have helped over the past 4 years on the various working committees. This was a large amount of work to turn out all of the updates, all 7 of the updates. And as I say, either directly or indirectly, these people contributed to the WHO. The WHO expert editorial group consisted of these 12 individuals, 10 of whom are neuropathologists and 2 of whom are oncologists, either pediatric neuro-oncology or adult neuro-oncology. As I say, the book is due out in the next few months. And for those of you eager to hear more about the kinds of summaries that I've just gone through, the review article by all of us will be coming out in press in neuro-oncology within the next couple of weeks. So thank you very much, and I look forward to taking questions.